Thank you, everyone. For those who may not see me or can just hear my voice, I am currently in my office at home. I do have two guitars behind me. I do not play the guitar, unfortunately. So, although I wish I did, they have now served more as just ornamental, if you will. Have a beard. I am wearing a purple shirt for those who cannot see me. And I'm very excited to be here talking with you all tonight on addressing the impact of cancer care on sexual health and LGBTQ plus communities. And I'm even more excited to be sharing this conversation with one of my favorite people, Barbara Carrellas, who I'll introduce a little bit later as well. So just a little bit on myself. My name is Jason Domogauer. My pronouns are he, him. I'm a radiation oncologist, and I'm also director of Perlmutter Cancer Center's LGBTQ plus cancer care and research program, amongst other titles that I have, but this is the one that's most relevant for today. Just a brief outline, we'll be going over some terminology, LGBTQ plus cancer disparities, sexual health considerations for LGBTQ plus communities, and discussing sexuality and relationships, which will be largely focused on by Barbara. The focus audience for this presentation is both for healthcare providers and clinicians, as well as patients as well. So we really try to make this a diverse conversation. So some of this may be new information, some of it may be familiar to you, but really thought it'd be very important to start with a good foundation. So really focusing on terminology. So when focusing on terminology, there's four major concepts of identity that we really want to introduce and start with. So sex assigned at birth or clinical sex is one of the first identities that we're all given at birth. And this is generally assigned to us by a medical provider based upon a combination of chromosomes, hormones, secondary sex characteristics, external genitalia, and genitals. Sexual orientation is more about who, as a verb behavior, who we are sexually, romantically, emotionally attracted to. Gender identity is how we internally view ourselves, and that is who we see when we look back at the mirror. Gender expression is how you communicate your gender or gender identity to the outside world. And it's very important to note that this can be very contextual based upon the environment you live, the society, the culture you exist in. And very importantly, these all exist on a spectrum. So it's not, and they're oftentimes not fixed. So we often change as we grow, our identities will change as well. So some important terminology in regard to gender identity. So someone who is transgender man or transmasculine is someone whose sex assigned at birth was female, whose gender identity is man or more masculine. Someone who identifies as transgender, a transgender woman, or transfeminine is someone whose sex assigned at birth was male, and whose gender identity is a woman. Cisgender is someone whose sex assigned at birth and gender identity corresponds with one another. And also the terms two-spirit is a person of indigenous background whose identity identifies as having both a masculine and feminine spirit. And some indigenous groups also use this term for sexual orientation as well. Did leave out or wasn't included non-binary individuals in terms of gender identity, and I apologize for that because it's a very important aspect as we talk about the real richness of identity. And so avoiding the assumption that everybody exists in a binary spectrum is incorrect. So there's a lot of individuals who identify as non-binary or gender fluid or gender expansive. So these are all very important things to consider, and asking patients how they identify themselves. Also, what was not included that's also very important is those who identify as intersex. And so this really speaks to the richness and the range of human experiences and identities. And that's why it's really important for clinicians to engage with patients on how they identify.
Gender, quote, gender nonconforming people, meaning not conforming to the binary, are in a near state of panic right now, given the potential political implications and the kind of war on trans people that has proliferated in the past months, past year. So please know that if you are dealing with a non-binary, a trans person, uh, they're already hyper terrified as a population, and just be aware of that. So not only might they be facing cancer, but God knows what else they might be facing. So just know that, please. Handle with care.
And like I said, and sexual orientation, again, is another terminology that we want to go through. So someone who identifies lesbian or a gay woman is a person who identifies as a woman who's emotionally or sexually attracted to other women or other women. A gay man is someone who identifies as a man who is emotionally or sexually attracted to other men. Someone who's bisexual is sexually attracted to both men and women and can also be attracted to individuals who do not exist on a gender binary as well. Heterosexual or someone who's straight is attracted to someone of the opposite gender. And someone who's asexual just may not have as much or has little sexual attraction to others, which is important, especially relevant in this conversation as we talk about sexuality and sexual health. Knowing that one's sexuality does not mean they have to be exclusively with another person, but one's self-sexuality can also be important. And we also know that LGBTQ plus communities exist in all racial, ethnic, religious groups. And so we are very rich communities that doesn't exist with one group. So it's really important for us to be very individualized as we have this holistic conversation. So why is it important that we talk about cancer and cancer disparities in LGBTQ plus communities? So the LGBTQ plus population is expected to be around 7 to 10% based upon where you're looking at that information. And it's been identified by the NIH to be a medically underserved population, often marginalized in a predominantly heterosexual and cisgender normative society. And recent data has shown that the population is growing. And it's especially growing in those who identify as younger groups, with a lot of individuals identifying as queer, which is another term that has a lot of history to it, which has been used as a derogatory term and is oftentimes not really favored by older populations, which has been historically utilized in a derogatory way. But it has been more reclaimed by the younger populations as a way of saying, I identify as something other than heterosexual and straight, so I don't fit into this box. And there's a growing population that identifies in this space. So we know cancer disproportionately impacts LGBTQ plus populations throughout the cancer care continuum, and that's from prevention, early detection and diagnosis, to treatment, to cancer outcomes and end of life. And there's been concerted efforts in other health disparity domains in regard to race, ethnicity, social class, disability, and others, but there has not been as much efforts to address cancer disparities based upon sexual orientation and gender identity. And we all can kind of appreciate the elephant in the room that we're likely to be entering into an era where these conversations and research efforts may even be further thwarted based upon political situations. And this leads to a potential ignored epidemic of around 20 million cancer survivors in 2020, which, if you take those numbers that we introduced earlier, equates around 1.4 million LGBTQ plus cancer survivors. So this is a very important, often understudied, under-discussed population. And we know further that just in the general healthcare landscape, that a lot of individuals are either overtly denied care, perceive that they're going to be denied care, or have just avoided the healthcare system, which leads to a lot of mental health and just overall health crises. One striking statistic is around 41% of transgender, gender expansive persons have attempted suicide, which is horrific when you look at the comparison of 1.6% of the general population. And more than half of the individuals that have low household income and live below the poverty line. So you can imagine the impact this has on one's overarching health and long-term chronic health conditions. LGBTQ plus persons, again, oftentimes refrain from seeing a physician due to fear of discrimination, have had negative healthcare experiences, and have decided to obtaining healthcare that they need or avoided healthcare that they need because of being mistreated. So you can imagine that this can impact cancer screenings and outcomes. And this is even further supported when we look at the LGBTQ plus communities under attack. So the ACLU has a webpage, and I encourage you all to look at this. At the time of me pulling this data, there have been 559 anti-LGBTQ plus bills introduced in the United States this past year. And we anticipate that to become even more ramped up. And a lot of these bills have been targeted towards transgender diverse communities, especially the adolescent young adults. So this is creating the potential for a future negative health impact, because we can see that by having this perceived threat, it leads to mental health conditions and avoidance of healthcare. Focusing on individuals with cancer each year, there's around 81,000 sexual and gender minorities, another more research-based term for LGBTQ plus communities, diagnosed with cancer each year. And speaking towards the earlier point, it's not a homogenous population. So lesbian women, bisexual women, gay men, transgender individuals will all have different, as well as some shared barriers or predispositions to care and impact and disparities. And a lot of this starts with early detection and screening. So there's a lot of people are less likely to receive preventative services for cancer, lack of trusted and qualified primary care provider, lack of sufficient health insurance, prior negative experiences, the gendering of cancer screening. So someone who's trans masculine or trans man who goes in for a mammogram may be placed into a pink gown, sitting in a waiting room with cisgendered women and may not feel welcomed in that space. And there's instances where they maybe have a dead name used or just being misgendered in that space. And we know cancer screening is not a one and done. So if you have one negative experience and then you're trying to advocate for yourself and you have another negative experience, it's not hard to perceive that it's going to be harder to get people to continue with that care if they are not feeling welcomed and affirmed in those spaces. And we're not having a lot of clinicians having the proper knowledge on how to adequately care for LGBTQ plus populations, which leads to also a lack of knowledge on screening recommendations and unfortunately some overt denial of care by medical providers, or what's potentially going to be introduced, legal efforts to prevent care and discussions about care. So this all sets up why it's important to talk about sexual health and considerations for LGBTQ plus communities, especially those dealing with a cancer diagnosis. Knowing that such groups are already fearful or hesitant to discuss their identities, and then you introduce a topic that is oftentimes still considered taboo in the medical community. So you're really setting up a perfect storm of not having proper care introduced. So we're really here to try to shed some light on this and give tools and skills on how to engage with your provider as a patient or with your patient as a clinician or provider. And so why is this important? Sexual health is a quality of life issue. Engaging in pleasurable sexual behaviors is an essential human function throughout the lifespan. It's not something that we age out of, and it has a significant role in overall well-being, an important aspect of cancer survivorship. And again, as I introduced earlier, that does not always mean it has to be with another person. Individual sexual health is also very important. And sexual dysfunction or poor sexual health after cancer treatment is very common in all populations. So effective functional anatomy-specific interventions that prevent or can mitigate treatment effects on sexual tissues are needed. So how can we avoid overtreatment? And how do we tailor conversations with the knowledge of what our patients' identities are and their sexual practices? So what are some of the common sexual side effects from cancer treatments? And there's quite a few. Decrease, and they're not all focused on cancers of the genitals or the pelvis. So it's really important that, hey, if a patient comes in with a breast cancer or the patient comes in with something, a lung cancer, for example, it doesn't mean that we do not need to discuss sexual health. It is something that is important for all patients, regardless of the cancer they're diagnosed with. So some things can be decreased libido or low sex drive, decreased erectile function in male-bodied individuals, as well as female-bodied individuals. There's a lot of conversations that do not happen in those with female bodies because a lot of the work and efforts that you'll see are really focused on male-bodied individuals. And so there's a lot of space to make up and a lot of gaps for those who are female-bodied individuals. Vaginal dryness for cis and transmasculine patients. Vaginal stenosis or the narrowing and shortening of the vaginal canal. Difficulty reaching orgasm. Pain during intercourse, whether vaginal, anal, receptive. Changes in body image and changes in relationships. So these are all things that can be impacted during cancer treatments. And what are some of the reasons that are causes of these symptoms? So a multitude of reasons can kind of all either one of these or the multitude. So systemic therapy, you can have hormone therapy, either anti-estrogen or anti-testosterone, which can impact our normal endogenous hormones. This can also be impactful for those who are under a gender-affirming hormone care. So these are important conversations to have. Chemotherapy can lead to fatigue. It can lead to neuropathic changes where it impacts the nerves and functioning. Radiation can lead to a lot of fibrosis or tissue remodeling. Surgery can have a direct impact on the anatomy and the tissue. as well as the mental effects of a cancer diagnosis. We know that patients have an increased risk of depression versus with a cancer diagnosis and at any point during the cancer diagnosis. And these can increase, it can lead to rates of 41% of depression in cancer patients, and that's in comparison to around 6% of the general population. These treatments can lead to vascular injury, nerve injury, scar tissue fibrosis, and decrease in hormone production. So you can see that any one of these alone can change how one's sexual functioning can change one's sexual functioning. And are you alone? No. There's a lot of individuals who really deal with the sequelae of treatments on their sexual function. So it's really, we're here to have these conversation starters, and they can be as simple as, do you have any sexual health concerns? And this can be from the provider or the clinician to the patient, as well from the patient, I have concerns about my sexual health, or how can this treatment impact my sexual health? But coming from a patient's perspective, while empowering, is also how do I navigate and advocate this in a situation where there may be a power dynamic that's at play? So it's important to understand that. Fortunately, there has been increased research in this space, although very scant. So new research has been starting to formulate beginning in 2000s, and a lot of it has been focused in on male-bodied individuals with prostate cancer. At the time of this, the entire literature is around 150 papers, mostly qualitative or case reports. So not really going into the depth that we have for a lot of other cancer-focused research, like randomized clinical trials, things along those lines. And oftentimes, data on sexual orientation is not captured in a lot of national registries. So we still remain an invisible population in the cancer space. There are some diagnostic and outcome differences between heterosexual and non-heterosexual men treated for prostate cancer. So one of these studies assessed treatment patterns in 460 heterosexual men, abbreviated as HSM, as well as 92 men who have sex with men, abbreviated as men who have sex with men, or MSM. They found that there were similar rates of those who underwent surgery, as well as those who underwent radiation, the two predominant modalities of treatment for early stage prostate cancer. They then asked patients about their role in sex to assist with treatment choice. They found that those who were the receptive partner, receptive anal partner for those men who have sex with men, surgery for receptive partners avoided rectal fibrosis from radiation and would generally be the predominant modality that would be recommended if these conversations were happening. Radiation for the insertive partner, or the top, would avoid initial issues with erectile dysfunction from surgery, but it's really important to have these conversations for those who identify as versatile, or those who engage in both receptive as well as insertive anal intercourse. So it's really important that we have these conversations to direct and tailor care. Erectile function, they saw that higher levels of bother seen in men who have sex with men, and there was a lot of expectation of having an active sex life into their later years. Again, we do not age out of sexuality. Loss of opportunity to explore recently accepted sexuality. A lot of individuals have come to an acceptance or exploration of their sexuality later in life, and I had a specific patient that had this realization as well. Firmer erections have generally been found to be needed for insertive anal intercourse compared to vaginal intercourse. So a lot of the survey tools that we use to gauge sexual health is very much tailored towards the heterosexual male-bodied patients who, if they're engaging in intercourse, is oftentimes insertive vaginal intercourse. There's also a component of ejaculatory function, lack of orgasm, decreased orgasm, pain with orgasm after radical prostatectomy or removal of the prostate, more bother with loss of ejaculatory function. And potential explanations can be there's more of awareness, growing attention to the management of ejaculate in those who have diagnosed with HIV, as well as the cultural context of the pleasure of seeing a visual evidence of satisfaction, as well as this masculinity of an ejaculate. And there's been a lot of exploration of sex roles, so really speaking to the partnership in these spaces. So the insertive partner or top may be more bothered by an erection or lack of erection or lack of ejaculation. The receptive partner or bottom may be more bothered by pain with receptive anal intercourse. And the versatile partners may have more of a broader range of concern or may be more flexible in these spaces. And importantly, treatment can lead to changes in sexual roles or partnerships. So the insertive top may become, or the introceptive bottom may need to change their roles, or they may need to look outside the relationship for sexual fulfillment. So this can lead to loss of sexual identity. The insertive partners did not switch because it did not align with their personality, or they did not find new position pleasurable. And it's not necessarily viewed negatively. Repositioning can allow for sexual engagement after treatment, but a lot of this should be a conversation that is ongoing. So starting from the initial discussion of treatment and diagnosis, as well as continued engagement during treatment, as well as into the survivorship phases. Because as you can imagine, these can lead to relationship difficulties, personal identity changes, and so a lot of support oftentimes is needed in these spaces. Importantly, there's also a need for consideration for those who identify as transgender or gender diverse who may have had gender affirming surgeries, because it's important for us, for the clinicians, to understand the anatomy and how that anatomy changes can lead to changes in sexual health. As a radiation oncologist, it's important for me to know what the anatomy, if I'm treating a pelvic malignancy, what does the patient's internal anatomy look like, and how do I do my best job in order to prioritize the therapeutic benefits of treatment while minimizing the side effects. So this can be very important in a reconstructed pelvis for somebody who's had gender affirming surgery, because I need to make sure that I am not over treating a specific area, and that I'm also covering lymphatic changes or the lymph nodes that are there, because they do get altered in any type of pelvis that's had surgery, regardless if it's a pelvis for gender affirming surgery. So it's very important to have these conversations, both to provide the best care and for the patient to be best able to advocate for what their needs and concerns are. The same is true for an individual who's undergone feminizing surgery, or an individual who is sex assigned at birth male, whose gender identity is a woman or female, or someone who's gender diverse who has a female pelvis, or a reconstructed female pelvis. And this can be very important because these individuals will have something called a neo-vagina or a created vagina. And this can be done in different modalities based upon the surgery. So also that awareness of what type of surgery was used is very important for the clinician to be able to properly educate and talk about the potential side effects that may be introduced from various treatments. So what are some interventions? So what we know from the dermatologic vaginal toxicities: moisturizers and lubricants can be very helpful if we're having vaginal dryness, which can result from hormone therapies or lack or suppression of hormones, estrogen, androgens for estrogen sensitive genital urinary tissues. So how can we ensure that we're providing the benefit of estrogens but also being aware of the potential harm that estrogens can be introducing for hormone-driven malignancies such as breast cancer, such as prostate cancer? And so there are different types of hormones that can be utilized that are more focal or topical, that can help provide the benefits in that focal area that have limited absorption systemically, so have a less chance of driving that malignancy, which also has a lot of relevance within the transgender community who may be on estrogen therapy. And that becomes a very important conversation, because we don't want to default that you must come off hormones, because that can be very impactful in a negative way for individuals where this is a component of their identity. So it really becomes a tailored individual conversation. Dilators for vaginal and pelvic floor dysfunction, as well as anal dilators as well for certain individuals with that are receiving focal therapy to the pelvis. And for those without a sexual health survivorship clinic, there are other resources available in various spaces to really help individuals through both the physical aspects of this as well as the psychosocial as well. So what can we do together as a collective? Everyone, ask about the importance of sexual health now and into the future. So this is really a shared conversation that we need to be having together. Clinicians really have an onus to have a conversation starter about sexual orientation and gender identity, and then not just for the checking a box, but utilizing this information in conversations with patients. And use what we know: moisturizers, lubricants, estrogens for estrogen sensitive genital urinary tissues, dilators for vaginal, anal, and pelvic floor dysfunction, and utilization of our pelvic floor physical therapists. For those, again, without sexual health survivorship clinics, connect people. Look at what resources are available both within institutions as well as outside the institutions, because this is really where this multidisciplinary, interdisciplinary approach is very important for that holistic approach to care. And build what we don't know. For clinicians, include structures in your plans and learn from them. Really be curious. Is what I'm doing going to cause harm? If there's a lack of information, let's try to fill the gaps together. Consider using advanced technology. So as a radiation oncologist, how can I use the more sophisticated radiation treatments to move the dosing away from these sensitive structures? And let's do better at enrolling on clinical trials, which have an emphasis on functional anatomy specific interventions, as well as patient outcomes and survivorship. So, what are some of the conclusions and takeaway? LGBTQ plus patients face structural and interpersonal barriers to equitable and affirming care. We need to work on that and we need to do better, especially as we're entering an era where care is going to be impacted. And we know that it is, we just know the full extent of which. Sexual minorities have specific concerns and outcomes with cancer treatments, some of which are shared, some of them are unique. Further, the sex-specific roles and identities are dynamic of a patient's play into dynamics of a patient play into both bother of these outcomes. So we really want to make sure we're engaging with our patients on what's important to them and their relationships. And how do we use different interventions at the level of improving provider cultural competency, increasing health outcomes data, and awareness are necessary to alleviate disparities. So we really need to improve our education on these topics to do better for our patients as well as both now and into the future. So I really want to thank everyone for their time and attention. This is my contact information, so always happy to answer any questions that people may have in this evolving space. And now I'm going to turn it over to Barbara Carrellas, who is my partner in crime on this presentation. So I'm going to stop sharing.
I am Barbara Carrellas. I am an author. I wrote a book called Urban Tantra, which was, I'm told, the first LGBTQ inclusive tantric sex book. I'm the founder of Urban Tantra as a professional worldwide collective of sexuality professionals and practitioners. And I am the partner of a kinky transgender partner of 27 years who is a survivor of 4 cancers. So that's what I bring to the table here. I am sitting in a room that's primarily white. There's a fake animal skin throw behind me. There's a picture of a pug dog on the wall, and I am blonde with pink highlights in my hair, really crazy round black and white glasses, and a crazy print red, green, and white dress. Okay, let's go. Jason, thank you so much. That was such an incredible presentation. So spot on. I'll I'll pick up where you left off, I think. The effects of cancer and cancer treatments on sexuality and intimacy are seriously overlooked in the American medical system. If you spend a few minutes in any peer-to-peer support group on Facebook or on Reddit, you'll see how badly sexual concerns are overlooked and how devastating this is for people. And this is doubly true of queer people, as Jason was saying. Because even when the effects of cancer treatment on sex and intimacy are acknowledged, these efforts are unconsciously and systemically biased. The default assumption is that everyone is a monogamous heterosexual who engages in penis and vagina penetration for their sexual pleasure. That leaves a huge swath of queer people out. Now, I'm using the word queer the way I often use it, and here today, as an umbrella term. For me, queer encompasses not only LGBT, lesbian, gay, bisexual, transgender, intersex people, but also heterosexual, cisgendered, kinky people and people in non-monogamous relationships. Although my focus is primarily on the LGBTI kinky non-monogamous grouping. If you happen to be heterosexual and cisgender, don't leave, stay for the party because this will apply to you as well. Let's look at how cancer and cancer treatment can affect queer sexual relationships. Let me share my screen. And there we go. Let's start out by looking at non-monogamy. Uh, by the way, there's no quiz at the end of this. This is just a lot of information to explain to you some variations in non-monogamy that you might not be aware of. Non-monogamous people, they might be unpartnered or in couples or in thruples, that would be three, or quads, four, and maybe some other configuration. Some may have one primary partner and some other lovers. The thruples or quads might be open, meaning the members of the thruple or quad might have sex with other people, or it might be closed and they just have sex amongst themselves. Some people prefer to have all their partners and loved ones be friendly with one another and spend plenty of quality time together. That is sometimes called kitchen table polyamory. Some prefer to keep their partners separate with little or no interaction with each other, though is sometimes referred to as parallel polyamory. Some may choose not to live with anyone or mingle finances with anyone. They may consider themselves their own primary partner, solo polyamory. Um, some couples enjoy swinging being enjoying sex, play with other people, often at parties, and often it's couples playing with couples. Not always, but often. Basically, non monogamy is only limited to the imagination and the time management skills of the people involved. Then there are the kinky folks, people who enjoy BDSM. The most important quality of BDSM is its consensual nature. Everything done under the umbrella of BDSM is a consensual activity. There is these three chapters, branches of BDSM can, some people are fond of all of them. Some people are only fond of one or two, but they would be bondage and discipline, domination and submission, power exchange, and intense sensations, sadism and masochism. And for those who do play with pain, they make a very important distinction between the good pain they enjoy in BDSM and the bad pain they feel from an injury or an illness. This is super important because I've run into more than one person who says the only time they are out of pain is when they are playing, meaning when they are receiving good pain, and that the effects of good pain can eliminate their bad pain for up to 5 days after a night or a weekend of good pain. So, may be important to know that. Now, I want you to pretend for a moment that you are a bisexual male cancer patient named Dave, and you're in a throuple with a man and a trans woman. In this throuple relationship, you, Dave, are the dominant, and the other man and the trans woman are your submissives. Okay? Now, imagine all the ways you could be misunderstood in a cancer treatment facility that isn't NYU Perlmutter. Just think about that. The first thing that would likely happen is your relationship would be invisible. It would likely be assumed that your two lovers, partners, submissives were a married couple and you were their friend, or they might be your brother and sister. This would make all three of you feel how? Probably pretty guarded, pretty defensive, pretty unsafe. But what if that practitioner were to say, how nice to see that Dave has such excellent support. My name is Barbara, and I'm a registered nurse here, and I'm here to take a blood sample or blood pressure or whatever. And you two are? Now, if they don't offer more than their names, I might say in the friendliest, most genuinely curious manner I've got, and what's your relationship with Dave? And whatever their answers, I would smile approvingly. And here's why that approach of acceptance matters so much. A friend of mine, I'll call her Casey, is a cisgendered female, queer registered nurse who has cared for and lost two long-term lovers to cancer. I consulted with her on this project, and she offered me several stories that show both sides of the fence that she has walked on in these roles over the years. Uh, the first one, we found that providers often engaged in strange platonicization, her word, of our relationship when Claire was in the hospital. Like I'd be rubbing Claire's feet, which was the only place she could stand to be touched when she was having respiratory distress, and the nurse would say something like, "Oh, I could use a good foot rub myself." And that was fucking creepy. Like I would never say that to a heterosexual couple. Or a nurse's aide would ask if I was her sister. Like, what the hell? I was not giving her a sisterly foot rub. Okay. I refer to this as systemic heterosexuality. The work of the truly fantastic team at NYU. It's the LGBTQ Cancer Care and Research Program has worked for the past 5 years with fierce determination to dismantle this systemic bias, and they are doing an amazing job. More later on that. Now let's look at the power exchange piece of this relationship with Dave. Here's my queer nurse friend again. Claire and I were in a dominant submissive relationship. You know, it's lovely when providers are able to talk with the patient and their person in a way that preserves that dynamic. I remember an ER nurse who insisted loudly that I, the submissive, should make Claire, the dominant with cancer, drink the contrast before a CT scan. Claire was super sick, so I did manage to cajole it into her. But I would have had a much better time of it if the nurse hadn't phrased it that way. This is possible. I watched providers adapt their language all the time to the unspoken dynamics of heterosexual couples. All they would need to do is pay attention and not be judgy. Another queer cancer patient said to me, "Please ask providers not to assume relationships. We patients don't have the energy to educate you." Chosen families. Queer people often have extended chosen families, meaning we've created family groups where the members are not related by blood. Chosen families are extremely important, especially to queer people who may not have supportive blood families. If you are queer and have chosen family and or romantic partners you are not legally married to, get your legal medical paperwork straightened out now. Do it now. Political changes are coming that may make it more difficult later. Some of the relationships you may choose to protect are here. The Chosen Family Law Center is an organization, not for profit, low or no cost, made up of pro bono queer and trans attorneys who will help you create the legal paperwork to be family. Paperwork that legal documents that can't be challenged. It's much easier for providers, medical providers, to treat you like the family you are if at least one of you has the legal right, such as medical power of attorney, to be there and to make decisions if the patient can't. So please, get on that soon. Now, I'll stop sharing for a moment. Let's talk about sex, specifically kinky queer sex. So you can consider that a content warning if you need one. Here are some examples of questions that have come up for my queer kinky friends living with cancer that you might not have thought of. For example, is it safe to share bodily fluids? Here's a question. When patients are getting hardcore chemo, they're often told to close the lid when they flush the toilet to avoid exposing other folks to potential particles in urine aerosolized by the flushing. Does that mean we shouldn't be exchanging body fluids directly? Is oral sex okay? What if the patient is an ejaculator, so there's lots of fluid involved? I can remember doing piss play with a lover and I could smell the chemo in the piss. I'm still alive, so I guess it wasn't acutely dangerous, but was that safe? Chemo in exchange of bodily fluids. What a very good question. Here's another question. This one involves bondage. I had a double mastectomy with the removal of some lymph nodes. The doctor told me I could not even get a massage on the arm affected by the lymphedema and the limited shoulder movement. Does that mean I can't get tied up anymore? Then there's a question from a person who likes receiving impact play with toys that leave marks. Marks being bruises, and she really enjoys the marks. She wants to know if any of her meds might make her more likely to form dangerous clots or not to clot at all. And speaking of BDSM, where I said the foundational principle is consent, there are questions around consent. Again, this is my friend Casey speaking. It's difficult to parse consent when one party is on opiates or benzos or the like. Like if my partner initiated sexual activity after a pain crisis when she still is on a ton of morphine, it seems to me like that's having sex with a drunk person. But she said, well, that's part of being sick. So you have to accept sometimes that we're having sex when I am very high. I worried about both the consent and about doing something that was going to cause her real physical harm that she wasn't aware of because of the opioid load. Now, let's acknowledge that providers are not erotic mind readers. They do not know what you like to do for fun. They can't possibly imagine all the things you might get up to. But providers can create an accepting, curious, non-judgmental environment so you can ask if an exchange of bodily fluids is safe after chemo, or if some rough play is safe after surgery, or if you will still have any feeling left in a particularly important erogenous zone. This next bit is for people living with cancer or who might one day live with cancer or might live with someone who has cancer. Cancer changes everything. It changes things physically, emotionally, psychically, and spiritually. And ideally, people need to prepare in advance for what might happen, at least to the extent that they can, especially the very real possibility of a complete loss of interest in sex, at least temporarily. And we don't know how long temporarily might be. They need to have this discussion with their partner or partners before this happens, before they're too tired to think of the alternatives. So for patients, please don't wait until you are deep in the throes of treatment to ask yourself this really simple but vital question. Why do you do sex? What's the big payoff? What's your highest value around sex? What do you get out of it? For some folks, it can be a connection to a partner, or it can be a connection to God, or to some nameless all that is. Or it might be a connection to nature or to your deepest, truest self. Maybe it's how you find inner peace. Maybe it's how you fly above all the noise. What is it for you? Because you may not be able to do sex exactly the way you used to before. In fact, you probably won't. The things that turned you on most might not be there anymore or might not be appealing anymore. The answer to the question, why do I do sex, is the ground, the jumping off point from which you can start to heal, reinvent, or recreate your sex life. There are thousands of different ways to be sexual. You can find new ones or adapt old ones and bring in new ones that will bring you joy if you know the answer to that one question. Providers along this line, in this vein, please tell people what might happen. Tell them what each procedure or medication might do to their bodies and emotions to the extent that you know. Hard as it might be for them to hear, it's preferable to the rage and the despair that I hear from people who felt blindsided and led on, who had no idea that they would no longer have erections or be able to enjoy penetration or a dozen other things. And let's remember that sex and intimacy are two entirely different things. Intimacy is not a euphemism for sexual activity, although it's often used that way in our sex negative culture. Sexuality means sexual expression, sexual activity, sexual decisions, sexual communication skills. Intimacy is separate from sexuality. It involves a distinctly separate set of skills. Intimacy needs can be met in ways other than sexual activity. Sexuality professionals can help people identify their most urgent needs and create strategies to meet them. Here's a bit more from Casey, the queer nurse and caregiver. Physical touch in general can be so difficult between caregivers and their romantic partners / care receivers. How do you differentiate touch that is sexual and touch that is therapeutic? And is that always essential? How can the partner with cancer communicate to their person about when they want to be touched or not touched? And how can their person learn not to take this personally? So much of being sick, especially with an intervention intensive disease like many cancers, is having so much painful or unpleasant touching or touching that leads to unpleasantness. For instance, accessing a port can hurt, and it also leads to the nausea of chemo. How can patients preserve desire for touch? She goes on, I think it would be helpful to have providers talk about other ways of having physical closeness that aren't fucking or play. I mean, at the time I just asked all my queer cancer friends, I didn't anticipate that I would get that kind of guidance from straight providers, but it would have been nice to have a professional to ask sometimes. Close quote. Medical providers, as Jason was saying, need to refer people to sexual professionals who can help. With the help of my Urban Tantra professional colleagues and community, we're putting together a referral list of people across several sexological practices who can offer support in these areas at a reduced cost. We're well aware that insurance will not cover us. In the meantime, there is, let me share screen again. Hang on. There is this directory of licensed kink, poly, trans, and LGBTQ affirmative therapists. These are talk therapists, they are not able to touch, who may accept insurance. In conclusion, providers don't need to be sex therapists, sex educators, or dungeon masters in order to provide queer sensitive support around sex and intimacy during cancer treatment and screening. Top-down policy changes and frontline training in a medical culture can change that medical culture in 5 years. It has at NYU, and I applaud their commitment. My closing advice: be open, be curious, be kind. Thank you.
So this is a dual question that Barbara and I can both answer, and Barbara has already given some insight on resources to access. There are also some other resources such as the National LGBT Cancer Network, National Cancer Institute, amongst others. Some of the limitations in the more top search group criteria is they don't always have specific referencing or focus on LGBTQ plus communities, as well as more kink or other relationship structures. So sometimes it's more a word of mouth as well as going into the resources that Barbara had mentioned. But there is hopefully growing evidence or growing opportunities in identifying providers. Oftentimes, different institutions will have out provider lists. So those are either providers who are queer or LGBTQ plus identified themselves, or they are affirming allies. And there's also a provider identifier list through the GLMA, who has a list for a national list of providers who self-identify onto those pages that have a multitude of different specialties. So it's a little bit, unfortunately, a little bit of a search and find at this point, but hopefully there'll be more concerted, more efforts to centralize these resources.
Yeah, we're definitely, several of us are working on even a simple Google Doc way
Mhm.
to make this information easier to find. Sexological body workers have a huge queer population amongst them. Sexological body work, you might want to check into them. I'm about to talk to one of their people who is particularly well versed in cancer to see if we can join forces to provide a resource list. And I, even as Dr. Domogauer said, that it does take a bit of hunting and a bit of research, but please, there are Facebook and groups and Reddit threads where people are helping each other, and I dug through those pretty intensely to find out what people seem to want and need, and there's a wealth of information peer to peer that should be helpful.
This is a very important question that has a lot of lack of data and a lot of evolution that we're hoping to see. But this is really where that shared decision making in a team-based approach to care is super, super important. So we at NYU have a richness of providers that work collectively together. So a combination of endocrinology, the gender affirming surgery team, if that's part of your care team, the medical oncology team, the radiation oncology or surgical oncology team. So it's how do we exist and navigate in a field where there's a lack of data in terms of what is the risk of both proceeding with gender affirming hormones, and what is the risk of stopping gender affirming hormones. So a lot of times we can do things like reducing the dose or adjusting or pausing during certain courses of treatments. So this is really an individualized conversation, but a really, really important one that should not default to just stopping altogether, because that can have really catastrophic effects as well. So it's really that shared conversation and that evolution together as a care team with the patient as the driver of that conversation. So it depends upon the individual on what testosterone is being used for in these situations. So if it's somebody who's on gender affirming testosterone, stopping of testosterone can lead to decrease in libido. It can lead to regression of secondary sexual characteristics. For someone who's on androgen deprivation or testosterone blocking therapy, if they're a male bodied individual with a prostate who's on that systemic therapy to reduce the hormones that could potentially be feeding the growth of the cancer, discontinuation can have an impact on potential growth or control of the disease. But it's also, we have an awareness that it does take, if you are suppressing the hormone, it does take some time for that hormone to come back up. We do know in individuals who are on testosterone suppressing therapy for, say, prostate cancer, they can have side effects such as weight gain, decreased libido, hot flashes, things along those lines that, towards Barbara's point, these are conversations about potential side effects the patient should be aware of, because that can change the conversation of what treatments they would be interested in pursuing. So depending upon how the person is engaging with testosterone for their own individual component can change what the potential side effects may be.
I think one could start with, are you, if asking a provider that you're not sure about, are you comfortable answering any sexual health questions? Is a good way to start, because if they squirm a lot, perhaps you'd want to look elsewhere for your answer. And, depending on their answer, and it's certainly possible to, as I, my example and thing, as opposed to saying, I like to do piss play with my partner, you might say, is it safe to share bodily fluids after chemo? It's a pretty medical kind of question. It doesn't get into specifically what you like to do in bed, and and kind of protects everybody's boundaries there. It's obviously interpersonal relations, be they with partners or with doctors, are, an art at best. But I think there's a way to do it where we are conscious of making the other person comfortable, but not at the expense of not getting our questions answered.
Mhm. I agree with that. Yeah, I think it's also the realization that the clinician may not have answers or may not, we don't necessarily have all the training in that space. So there may be a lot of shared learning in that space. But towards Barbara's point is this something the provider clinician is comfortable in working with the patient with? Or if they're not comfortable or don't have the knowledge, bringing in other team members to help answer those questions. But I think things like you said, or I have concerns about my sexual health. How does this treatment impact that? If the clinician opens back, like, tell me more, I think that shows curiosity and openness versus I don't have the answer for you. So I think it's
Or you can get out of it all. You can get, I honestly don't know, but I'll find out for you. I'll ask someone. It honors the person for asking, doesn't make them feel weird, and they will eventually get their answer because you actually will go ask someone.
Mhm, absolutely. So one of the things I people should be able to use the restroom. My personal belief is that people should be able to use the restroom that they are most comfortable using. One of the things that we're doing at NYU specifically is we're doing an inventory of restrooms and trying to ensure that restrooms are gender neutral, single stall as most as possible, and working towards implementing changing rooms or things like that. Sometimes you don't always have the capabilities. I know within my own department, we have gendered changing rooms and working on workflows to make sure people are able to use the changing room that best they most feel comfortable with, and giving training to staff to help assist patients if possible. It's something that is not this accessible for everyone depending upon where they're receiving care. And as Barbara was mentioning, the climate and culture is unfortunately not always welcoming. So it's something that's going to be evolving. Go ahead, Barbara.
To that point, I would say, I would just get very practical, and I go, where's my level of safety in this situation?
Yeah,
What is the safest choice to make?
it's true.
And in that, you can always go and ask whoever it is. I'm thinking theater, it would be the house manager. Where is the disabled restroom, please? Because no one is allowed to ask you what your disability is and whether or not you can go from downstairs. If you ask for the disabled or the handicapped restroom, they have to point you to it. And that will get you out of an unsafe situation. Does it answer questions of fairness and human rights? Absolutely not, but you won't get beat up that night or arrested. It's hard from the amount of information in that question, but obviously I would start with a trauma therapist, um, because you're telling me already that you know it's a trauma issue. Depending on what the trauma is, if it winds up being, like of a sexual nature and you don't feel comfortable having sex with your partner, I think, what can I say? Honesty and calling a timeout on sex is allowed. You do not have to suffer through sex because you think you should, because your partner's been without it so long, but because you've been sick. Just you can make an arrangement where they can pleasure themselves, or you can stay with them while they do, or rearrange some other sexual situation that keeps you out of being triggered by whatever the trauma was. And if that means no contact, that's no contact while you heal. It's just what happens in cancer.
Yeah.
And your partner may also benefit from therapy and or a cancer caregiver partner support group.
Yeah. And also engage, if possible, engage with, if you feel comfortable doing so, with your clinician or provider. Sometimes there are some side effects that are resulting from treatment that may heal over time. And towards Barbara's point, that there may be time to heal, that these will get better, or there's different interventions or medications that can help alleviate some of the symptoms while you're healing. At least having that knowledge on what to anticipate, again, that ongoing conversation into that survivorship space as well can be useful. And then, as Barbara beautifully said during her time too, is how to like navigate intimacy during the sexual healing or the physical healing aspect. So how to combine those two together and getting the resources um, to help with that, because trauma can present itself in many different ways. So it's a team, another example of a really good team-based approach to care that should be individualized. I just want to give a huge shout out to Barbara and Kate, who are members of the LGBTQ plus research program and care, for being PFAC members, or Patient and Family Advisory Council. The program would not be anything like it is today without their support and guidance and feedback, because we're doing this all together. So if anybody on the call is interested in learning more, feel free to reach out to me, because this is really where we have this really important dialogue to make sure the patient is the voice we're listening to. So I just want to thank you, Barbara, for all that you do.
Thank you. My pleasure.